Welcome to Impactful Chats. I'm Malin Martinez,
And hi, I'm Seth Truger.
and we're here with Dr. Zach Rubin, an allergist and immunologist. Go ahead and let us know a little bit about yourself, Zach.
Hi, thanks for having me. So I'm an allergist immunologist out in DuPage County at Oak Brook Allergist. So I have several offices that I serve in Elmhurst, Naperville, Downers Grove, and Plainfield. And I'm really excited to be here to talk about COVID vaccines. As allergists, we have to counsel our patients a lot about allergic reactions to various things. And with COVID vaccine being on everybody's mind, it's something that I'm deeply passionate about talking with you today.
Right, and you've been giving everybody all this great advice on Twitter recently, so we thought we need to get him in here. We've taken all the questions that we've seen people ask you on Twitter, and we're just going to have kind of this lightning round where we have the perfect vaccine expert to just answer these questions all at once, all in one place. And so I think we're just gonna dive in and get started here.
Yeah, let's do it.
We'll start with, the really, really basics here. So, which vaccines are approved for use in the US right now?
Currently, it's the Pfizer and Moderna vaccines.
Okay. And what's the difference between these two vaccines?
There's very few differences. They're both considered to be mRNA vaccines. Really, it has to do with the dosing interval. So the Pfizer vaccine is spaced 3 weeks apart. The Moderna vaccine is spaced 4 weeks apart. And there's some other logistical issues in terms of transportation where the Pfizer vaccine requires sub-zero temperatures and does not last nearly as long as the Moderna vaccine does. The Moderna vaccine is a little bit more traditional in terms of storage. It can last for about a month in a traditional fridge once it's thawed.
Great. Can you tell us what is an mRNA vaccine?
So, an mRNA vaccine is a new type of technology in terms of being commercially available. However, we've been studying it for about the past 30 years. So, it's not technically new, and we've been studying it in influenza, Zika, and Ebola viruses. But what this type of technology does is instead of taking a killed or weakened version of the germ, we're actually taking messenger RNA that codes for a specific protein. In the sense of COVID-19 being caused by SARS-CoV-2 virus, it's only the mRNA that codes for the spike protein, which is responsible for infections. And so if we can take mRNA that codes for the spike protein, take it in this little fat nanoparticle, inject it into the body, our body then will create that protein, express it at cells, and then our immune system will look at it and say, hey, that's foreign, let's go after that. And it'll create these proteins called antibodies, which helps remember that infection as like little tags, so that if the germ comes in, as SARS-CoV-2 in this case, if it comes into contact with us, it'll then recognize it and mount an immune response quickly so that we don't get sick.
Gotcha. So, you told us then with that really comprehensive answer what an mRNA vaccine is, how it works. And I think in so many words, you said that the vaccine doesn't have any part of the virus in it. But can you clarify, does the vaccine have any component of the virus in it?
Absolutely not. There's no COVID particle whatsoever. It's just a transcript. So one way we can also think about this is if you go to a restaurant, right? The menu is the DNA, if we're going to make an analogy. When you make an order off that menu, the actual piece of paper that order is like the mRNA. And so that order is then taken to the chef to make your food or the protein. So in essence, people worry about, can this vaccine create genetic mutations? It's just not possible. You make your food, you make the protein, but that order doesn't change the menu, and the order gets thrown out pretty quickly. So the likelihood that it's going to create long-term side effects is very low, most likely.
Yeah. So, how effective are these vaccines?
They're very, very effective at preventing symptomatic COVID disease. So when we look at the Pfizer as an example, what they did in their large phase 3 trial, they said their primary endpoint was 1 week after the second dose. How many people in the vaccine group versus how many people in the placebo group got symptomatic COVID disease? And they found that it was 95% effective at preventing symptomatic COVID disease in the group that actually got the vaccine. Moderna was studied 2 weeks after the second dose, so a little bit later in terms of that primary endpoint. And it was roughly the same, just a little bit over 94% effective So they're both highly effective at preventing symptomatic disease. We don't know in terms of asymptomatic disease where you don't have symptoms. That's not what was studied in this case. So we have to be very clear on that wording.
Yeah, and going along with that, these vaccines were developed very quickly. How do we know they're safe?
That's a great point. So when the SARS-CoV-2 virus was first discovered and reported by the World Health Organization at the end of 2019, which is why we call it COVID-19, already scientists were looking at the virus and trying to create the mRNA that they were going to create the vaccine. So they were already developing this rather quickly. But we do these studies, phase 1, phase 2, phase 3, in order to get an FDA approval where we're recruiting a lot of people with these vaccines. So you may not be aware of this, but if we look at other vaccines that were already approved by the FDA, they use population sizes that were much smaller than actually the Pfizer Moderna. So for example, the shingles vaccine only had 17,000 trial participants who got the vaccine. That's not including placebo. But when we look at Pfizer's vaccine, there's 22,000 people who wanted to do this. We've had billions and billions of dollars more spent at creating the vaccine, at getting trial participants from all sorts of age ranges from 16 and above, which is quite remarkable. And so we were able to very quickly look at the safety and effectiveness of these vaccines. And every day people are reporting what's going on with these vaccines. We're still doing what we call phase 4 studies.
Yeah,
To monitor this.
I would also add that one of the paradoxes or silver linings of how bad the pandemic has been is that the target for the studies is a certain number of cases overall. So we're able to kind of get to that number of cases quickly because so many people were getting sick, unfortunately, mostly in the placebo arm.
Right. And unfortunately, it's getting more and more severe in terms of the number of cases, in terms of the number of deaths. And we're now seeing new variants related to these. So I know people are concerned about that. But so far, when we look at two of the newer variants, the one from UK and the one from South Africa, we're already starting to see relative effectiveness of these vaccines. And already Moderna is creating a booster to help combat some of these variants as well. So, I know a lot of people are wondering, hey, are we going to have to take a vaccine every year? That may be possible. Maybe.
And I thought one person on Twitter asked a really fair question. If you're not used to reading these trials and stuff, but how did they, as far as saying people in the placebo arm had more infections than people who got the actual vaccine, how did they actually go about that? Did they vaccinate half the people, give half of them placebo, and then expose them to people who had COVID, or how did that part work?
Right. So with a large trial like this that was randomized, meaning you don't know what you got, that helps reduce what we call bias towards a lot of behaviors that could happen. And so basically they were just monitoring people to see whether they got sick or not. And because there were so many people and they didn't know what they got, it's safe to assume that their behaviors are relatively the same in terms of the amount of physical distancing, the amount of mask wearing. It's going to be generalized to what the actual population is, which was somewhat, diverse, but also large as well.
Right. So it would have been the same exposure any of us could possibly get just from living in the world right now.
Exactly. It really simulates what the real world is like as best as possible for a study of this size.
Great.
Right. So there's been a lot of talk about side effects and adverse reactions. Can you talk about, just in general, what those mean, what the differences between the two?
Right. It can get very confusing when we throw out words like side effects and reactions, and it sounds quite scary. But let's put it this way. When you get a vaccine, it's natural to get symptoms related to your immune system actually working. So in both of these studies, approximately 80% of people experience some type of symptom related to the process of getting a vaccine. Most commonly, pain at the injection site. We're taking a needle and we're going to disrupt some of the muscle tissue there. So you're going to get pain. That's to be expected. But then other symptoms such as fatigue, headache, muscle pain, those types of symptoms are related to your immune system actually activating. And in that sense, we expect that to happen. With this type of vaccine, we're seeing that the second dose created more symptoms related to immune system activating. We also saw that younger people tended to be more affected than older people, which we don't really know why, but I suspect it's probably because younger people have a more robust immune system. So it's related to that. That's different than more severe adverse events that have occurred with these vaccines, and that's quite rare when you look at the studies. So, for example, in the Moderna trial, there were 3 people who about a week later developed facial swelling after getting the vaccine, and those were in people who had cosmetic fillers. We don't know exactly why that happened. It all resolved spontaneously, or it required some oral steroid use, but it was nothing that was considered to be life-threatening. Nobody died in these trials that was directly linked to those vaccines. People did pass away, unfortunately, but it was related to other causes. There was no causal relationship between that. And so overall, the actual serious adverse reactions that occurred were quite rare.
Okay. And so it sounds like, so then the side effects mostly have been fatigue, headache, and maybe some body aches. And as far as adverse reactions that happened in the trials, we don't really have, there weren't really any, it sounds like. Is that right?
Correct. It's quite rare. And so one of the ones that we're concerned about right now is severe allergic reactions, also known as anaphylaxis. And so we did find 1 case in the trial for Pfizer and none in the Moderna initially, which is quite low. And then there were all these reports that came out almost immediately after the vaccines were released of people getting anaphylaxis or that severe allergic reaction. First to the Pfizer, because that's the vaccine that came out first. And now we're seeing this with Moderna. But the CDC came out with 2 studies looking at both vaccines, and the actual case rate of anaphylaxis is quite low. So Moderna, it's 2.5 cases per 1 million dose, compared to Pfizer, which was 11 cases per 1 million. But that was to fewer vaccines. We're finding that as more and more people get vaccinated, those rates are lower, but that's still extremely rare. You're more likely to get hit by a car than to experience a severe allergic reaction to these vaccines.
Got it.
Yeah, so some other safety questions. Is it safe for pregnant and breastfeeding women?
So if you look at the FDA package insert in terms of who can actually get the vaccine, pregnant and breastfeeding women can actually get it. The problem is that we didn't study that population, and so we don't technically know the answer to that yet. But various organizations such as the American College of Obstetrics and Gynecology do promote getting vaccines in women who are pregnant, especially in people who work in settings where getting COVID is at a higher risk. So, for example, healthcare workers, because the risk of having severe outcomes from COVID when you're pregnant is much more likely compared to those potential risks that could be from the vaccine. Like I mentioned before, mRNA itself is short-lived in the body. So the likelihood that it causes long-term effects is low, but we just don't have that data to substantiate it this time.
Okay. I think also another question that a lot of people are asking is, can you spread the virus to others once you're fully vaccinated?
That's a great question. So we actually don't know the answer to that yet, which is why we should still wear our masks, still practice safe physical distancing as much as we can, because we don't know whether or not the vaccine prevents transmission. We know that the virus itself can enter through the nose and it could potentially stay there, but we don't know if the immune system can actually reach that site and reduce the shedding of the virus, which is why this is such a difficult question to answer, and it's best to play it safe until we know more.
Yeah, I think I'd also add, if these vaccines are about 95% effective, which is fantastic, that still means about 1 in 20 people don't build immunity. And, as you said earlier, we're starting to get a little bit better, but the pandemic's really bad right now. There's a lot of cases. So 1 in 20 of a lot is still a lot. So I think just that alone, most likely, most vaccines do protect against spread. So it's unlikely that this is going to be magically worse or different, although we've been pretty unlucky so far with the pandemic. So we'll see, but I think that alone, I think, is enough reason to keep up mitigation for now.
Right. And until we hit herd immunity, which that's another question people keep asking, that's the idea where enough people have been vaccinated where we're protecting everybody who can't get vaccinated. Unfortunately, that means children, they can't get vaccinated. So there is going to be this pool of children who will circulate the virus. And so really adults need to, when they can, get vaccinated and as quickly as possible, because if we have enough adults vaccinated, it may lead to herd immunity. Every vaccine is different in terms of how many people need to be vaccinated to hit that point. So measles, we need 95% of the population or more because it's a highly infectious agent. So we need a lot of people vaccinated. Polio, it's about 80%. So it's a little bit less. It's not as infectious, but still pretty high. So right now it's all speculation as in terms of what the actual percentage has to be. But obviously the closer we get to 100%, the more likely we're going to get there as quickly as possible to also prevent more variants from popping up and escaping the vaccines that we have right now.
Right. And then going back, you talked a little bit about anaphylaxis, but a lot of people had a lot of questions about anaphylaxis. So I want to make sure we hit specific points. And so you mentioned the numbers of people who had anaphylaxis in the trials. Are there any updated numbers since the public has been getting vaccinated now? Number of people who have had anaphylaxis?
Right. We're seeing that the numbers are going down with Pfizer in particular. That's getting closer to about 5 to 6 cases per 1 million. So that's really reassuring. Newer numbers for Moderna went slightly up. It went from like 2.5 to 2.8, which is negligible, honestly. And so why this is occurring, we don't actually know 100% right now. We have speculation that when we look at the ingredients to these vaccines, we're looking normally for things like food products, which that's not there. We look for antibiotics, that's not there. Certain preservatives aren't there as well. These are relatively clean vaccines, but the one new item that's in this vaccine compared to others is called polyethylene glycol. That's a substance that helps make the vaccine soluble. It helps protect the mRNA package and enter the cells. So that's a new portion that in literature, we see that it's quite rare for somebody to have an allergic reaction to that. However, we're not normally injecting polyethylene glycol into people. So it's a different route and could create different challenges that we're just learning about right now. And there's other types of immune reactions that are proposed that don't necessarily mean that it's one particular component or another. It's just kind of like a crowbar in that it'll just activate the immune system just by being there. And it's right now hard to predict, but fortunately very rare. So a lot of people who are having a history of anaphylaxis to other vaccines should talk with their doctor about whether they should get the vaccine or not. Technically they can, but definitely should wait 30 minutes because most of the anaphylactic cases occurred within 30 minutes of injection. People with food allergies should consider it as well as a precaution, drug allergies in general.
Yep. I will also add, polyethylene glycol is new, and it's a complicated name for a lot of people. It's also not that new. It's something that there's first of all there's a number of different types of polyethylene glycols I've learned recently. They're kind of most commonly used that we know about in medicine as a bowel prep or
Miralax,
Miralax, or I would go lightly, the big one people take before colonoscopies.
Right.
But there's a bunch of different chemical formulations of it, and it's used in some other medications, so it's not totally new to everybody. It's something that's been around for a while and is generally known to be safe, but unfortunately at this scale, people are going to have some reactions to it.
Yeah, absolutely. But keep in mind, it's also in household products too. I mean, if you have creams or makeup, it's in everything. That doesn't mean that it's harmful for you. It's just that we're seeing that it's being introduced differently and in a different size. So the type of peg that's seen in these vaccines is a smaller size than the one that you mentioned with bowel prep. The bowel prep size is much larger, and so it confers all sorts of these different nuanced questions that it's kind of beyond the scope of what we're talking about today.
Yeah.
Oh, go ahead.
Oh, I was just gonna kind of summarize. So it sounds like we're not positive the component of the vaccine that's causing the anaphylactic reactions. It might be the polyethylene glycol. If you have a history of anaphylaxis or a history of anaphylaxis to vaccines or a history of food allergies, the recommendation is you can still get the vaccine, but consider sticking around the vaccination clinic or the site for about 30 minutes. You can be monitored after you get your vaccination. Is that right?
Correct, because 90% of the anaphylactic reactions occur within the first 30 minutes. So the people who might be at the highest risk, those who have had severe allergic reactions in the past, should just wait. Make sure that there's an EpiPen available, that there's somebody who can look at you and make sure that you're okay.
Yeah. Should people do anything beforehand, like take Benadryl?
It's a great question. Absolutely not. It's not advised to take Benadryl beforehand because that's not going to prevent anaphylaxis in these cases. But also, The earliest sign of anaphylaxis for most people is having skin problems, so hives or swelling, and Benadryl can actually slow that process down. And we know that if somebody has anaphylaxis, the slower it takes to identify it and give epinephrine, the more likely there's going to be problems. Fortunately, no one has died from anaphylaxis due to these vaccines at this time. And with these types of recommendations, I think the risk of that happening is very, very, very low. But if people start trying to pre-treat themselves, then that could run into some issues.
I see. And then kind of along those lines about taking meds peri-vaccine, does taking ibuprofen or Tylenol, or, because these are anti-inflammatory drugs, right before or right after your vaccine, will that reduce your immune response and make the vaccine less effective?
So it's a great question. We don't fully know for this vaccine right now, but we have seen some earlier studies to other vaccines that showed a reduction in antibody production when taking ibuprofen or Tylenol beforehand or shortly thereafter. So the CDC actually did put out a statement saying you should not take any type of anti or fever reducing medicines beforehand. But if you experience symptoms that are severe or you have a fever afterwards, you can certainly take it at that time.
Yeah, and I would add, there's been, I think, a lot of discussion about the side effects, the aches, the headaches, the low grade fevers, things people have gotten. A lot of people don't get them. I'd say about, my network of healthcare workers, like half have had no problems whatsoever, no
Right,
symptoms, which
right,
doesn't mean your immune system's not working, but
right.
also like you don't need to pre-medicate because there's a good chance you just will feel fine. I will say I had a migraine for about 2 days leading up to my vaccine. That was not, obviously unrelated. It was before. I was taking Tylenol ibuprofen because I had a migraine, and I think the risk versus benefit was like if I feel like crap and don't want to get vaccinated, it's a much bigger problem.
Right, exactly. I mean, for me, my first dose, I had no symptoms. Second dose, I was really tired for 2 days. So it was a good excuse to be lazy for a little bit. But, you, you do what you need to do afterwards is really what the message has to be. Just there's really no benefit at this point to pre-treat.
Right. And yeah, I think that might be a good time to pause and say that we are three people who have been fully vaccinated. We both had our 2 doses. I had Pfizer. I don't know what you guys had.
Yep, me too.
Pfizer.
But we all had the Pfizer vaccine. It sounds like at least Zach and I, after the second dose, I also had a headache. I was super tired. I fell asleep in the car. And I had body aches. And then that was, I got the second vaccine about 7 o'clock at night. And this started at about noon the next day. And then I went to sleep and I woke up fine the next morning. And I did take Tylenol that day. It didn't seem to make much of a difference, but I survived.
Yeah, I had some pretty mild body aches. I was pretty tired for a couple days. And then probably about 5 days after my second one, I had some lymph nodes I could feel my underarm. But again, it's kind of normal stuff.
Yeah.
Right.
And then it
right.
went away. Right.
Yep,
And
all
it's
went away.
expected to have a lymph node be a little bit larger for a little while because your immune system's activated.
Yeah, exactly. So now the big stuff. How many people have died from getting the vaccine?
Nobody to this date at this point. Okay. So there's a lot of issues with people trying to take data and misconstrue it. So there's something called the Vaccine Adverse Event Reporting System. And so anytime anything might have any kind of relation to a vaccine with any type of severity, that will get voluntarily reported to this agency that's conjoint between the CDC and the FDA. And so if you go on there, you'll find that there's a little over 200 cases where somebody got a vaccine and then a few weeks later passed away, or it might even be a little bit shorter. But that doesn't mean that the vaccine caused the death. There's so many other factors we call confounding factors that come into play with this. So a lot of people in these categories were older, have a lot of comorbidities, and were unfortunately at risk of dying from other things that are common, such as heart disease, stroke, and things of that nature. Hank Aaron was one of those cases that has been put out there, people trying to blame the vaccine for his death. He got the vaccine 2.5 weeks prior. There's really no causal link at this time. Now, as we study this more and more, if we find that something like this actually has some type of causal link, sure, we'll report that out. But at this point, correlation does not mean causation.
Yeah, and I have a Twitter thread from yesterday, I think, where I went through some of the numbers, and basically we should expect about, I think, probably just from the pandemic and normal cause of death, about 10 times many people to be dying after the vaccine than have been reported. So we're actually doing better. Part of it is probably because a lot of people are young, healthy healthcare workers like us, but
Right.
Who knows?
Yeah. And so, Zach, I think you earlier, you kind of answered this question, but just to make sure it's clear that we're asking this exact question and this is what you were answering, will the mRNA vaccine alter your DNA?
No, it does not. It's not possible. Another way to think about it is this. The DNA is housed in the nucleus of the cell, and this mRNA cannot penetrate that nucleus. And so it's not going to be able to come back and then somehow reverse engineer your DNA. That's just biologically impossible. So also because the mRNA is short-lived, it's unlikely to create long-term side effects to what we know at this time.
Yeah, so you mentioned the facial swelling people with fillers. Is it safe to get the vaccine if you have fillers or Botox or cosmetic surgery?
So the 3 cases were specifically to fillers, not Botox. So Botox has nothing really to do with this. But as we've looked at those 3 cases, they resolved spontaneously or required an oral steroid. And so at this time, it's safe if you have a facial filler to get the vaccine. These events are quite rare.
Got it. And do I need the vaccine if I've had COVID? I saw that was a question a lot of people are asking on Twitter, and or if they're a long hauler or the people who had COVID and then continue to have these sort of lingering symptoms for months afterwards.
Right. So look, we don't know how long immunity lasts after getting COVID. We are safe to say that it's at least 90 days of protection, but there have been cases of people getting reinfected with COVID. And we know from previous vaccines and what we're starting to see evidence of that a vaccine will provide further protection. So anybody who has had COVID in any form should get vaccinated. Now, the follow-up question to that is, when should I get the vaccine? So the CDC recommends, and I agree, that if you had monoclonal antibody treatment where you were very sick in the hospital and you got that specialized type of treatment to treat COVID, you should wait 90 days. Because in that case, that type of treatment may disrupt the vaccine's efficacy. Outside of that, you can get the vaccine earlier, but you have to have completed your 10 days of isolation. You should have no fever for at least 24 hours, and your symptoms should be improving before you get a vaccine.
Yeah, it's interesting. I remember when I first read about that, I was like, wait, these are just the precautions for not getting other people sick. And that's the main thing. They don't want you getting other people the vaccines that are sick. It's not about whether or not you can get vaccinated when you're like getting over COVID.
Absolutely.
Right.
Go ahead.
Go ahead, Seth.
No. All right. So what do I do if I miss the recommended window for my second dose?
That's a great question. So you should just try to get it as soon as you can. That's the best answer. You can't get it before. You can't get it earlier. Like, hey, I got to go on vacation, and I want to take it 2 days early. You can't do that at this point. But if you're outside of that 3 to 4 week interval, you should just get it as soon as possible.
Yeah, but do I really need a second dose?
Yeah, you really do. The reason being is that with this type of technology and with what the studies are showing and thinking about it, the first dose creates antibodies. And we see early protection within about 12 to 14 days from the limited antibody production that happens. But if you don't have that second dose, those antibodies will wane. You're not likely going to make more. You need that second dose as a booster to create memory cells that will help remember the infection for hopefully at least 12 months, if not longer. We don't know exactly how long these vaccines will work for, but at least Moderna already said that they predict at least 12 months of protection.
Yeah, and I think a lot of people, a lot of pundits, a lot of people in the policy sphere have suggested, why don't we just do one dose for everybody and give twice as many people a vaccine? Mm-hmm. But I think, something that concerns me with that is if we're wrong, if one dose doesn't do anything, we wasted all those second doses on single doses that do nothing.
I agree. I know that there's a lot of politics involved with it, and also the distribution is a nightmare, honestly.
Yep.
But if we're going to protect people and go to what the study tells us, the 2-dose series confers approximately 95% of protection against symptomatic disease. And so we really need to prioritize that.
Yeah, and most vaccines take more than one dose, right? We get boosters for most
Absolutely.
stuff. Like I don't look up vaccine, like I don't know vaccine schedules. I look it up. It's a big table. It's complicated.
Right, right. I'm originally trained as a pediatrician, so I used to give this out all the time, and there really isn't any vaccine that's just one and you're done. It doesn't really work that way. So it'll be interesting to see how the Johnson & Johnson vaccine plays out. They haven't released the data completely yet for the 1-dose trial, but they do have a 2-dose trial happening right now. So they know that this could be a problem with that technology as well, and that's a totally different vaccine technology.
Right. So are there any absolute contraindications to the vaccine? Is there someone who should absolutely just not get the vaccine?
Right. So obviously age is the biggest. So for Pfizer, you can't get it if you're under 16. For Moderna, it's under 18. But really it has to come down to those severe allergic reactions. So if after the first dose you had a severe allergic reaction, you can't get the second dose. And if you have a known history of a severe allergic reaction to one of the components, you can't get the vaccine, which really is just about polyethylene glycol or the other actual issue is something called polysorbate, which is similar to polyethylene glycol.
Mm.
What about people on immunosuppressive meds for like transplants or cancer or autoimmune disease?
Right. So those are not absolute contraindications. You can still get the vaccine. The question becomes, the relative safety and effectiveness. Likely the effectiveness would be reduced since immunocompromised populations can't necessarily amount to the same type of immune response as healthier people, but it'll still be effective. To get a vaccine is much better than not having a vaccine, especially in a vulnerable population, such as those that are immunocompromised. And in terms of safety, there's a lot of organizations like the Immune Deficiency Foundation that does believe that it's safe. I ascribe to that as well, given how short-lived the actual vaccine is in the body.
Right. And so can you get this vaccine on the same day that you're scheduled to get a totally different vaccine?
So that's a great question. There's not a lot of guidance on this, and technically when we look at other vaccines, we typically give multiple vaccines on the same day, and that's fine. So technically it's probably fine, but there's not really any recommendation on that. Although when we're worried about all these side effects that present with these vaccines, it's probably best not to take anything else. And there are recommendations to say you need to wait at least 2 weeks before getting any other type of vaccine. But in my opinion, it's ideally 4 weeks.
Yeah, and my understanding is it really just as I said about monitoring for side effects, so that if something bad happens to you after the vaccine, it's not
Right.
which one of these is it from.
Right, exactly. So it's not going to necessarily reduce your efficacy with the vaccine. We just don't know if you had a lymph node here, was that from one vaccine or was it from the COVID vaccine? And we don't want that confusion when we're having these ongoing discussions about safety.
Mm-hmm.
Yeah. So when are kids going to get vaccinated?
So right now they're studying down to age 12 for both Pfizer and Moderna. We don't know exactly when that data is going to be published, but I'm hopeful that sometime within 2021 we'll get that data and get approval down to age 12. Now anything below that age is going to take a lot more time because the consent process to have families say, hey, would you like your child to get either a vaccine or a placebo and see what happens on something that is new, that's going to be challenging. But fortunately, as we get more and more people vaccinated, and if we get it down to age 12 quickly and get vaccines in those arms, we may not require vaccines for younger kids because we may get herd immunity. Who knows? And fortunately, most of the severe outcomes occur in older people.
Yeah. And along the lines of herd immunity, so you mentioned it earlier as far as the percentage of this that we need to reach herd immunity for this disease. Can you reiterate what that percent is? And then do you have any estimate just based on the rate at which we're vaccinating the population, when we'll reach that percent?
Right. So what I had mentioned earlier is that every germ in terms of what we vaccinate with has a different number because of how infectious that germ is. So measles, you need 95% of the population vaccinated to get herd immunity. For polio, it's about 80%. We don't know for COVID, in terms of how infectious it is, and with these new variants, that number is going to change, and we really don't understand where that's going to be. I doubt it's 95%, Is it in that 80% range? Maybe, but that's all speculation at this point. And in terms of when we would hit that herd immunity, we're expecting that the majority of the vaccine supply should be available by, late spring, early summer, in terms of when everybody will have access to it. We're vaccinating a little bit over 1 million people per day in the United States. That's great, but it's still rather slow for where we need to be. So we just got to do the best we can to get as many vaccines in as many arms as possible.
Yeah. So I'm the air doc. I got my shots a couple weeks ago. Can I go on a plane, go to movies, go to a restaurant?
Right. So keep in mind that with these vaccines, you have to wait some time before you actually reach that efficacy level. So for Pfizer, it's 1 week after the second dose. For Moderna, it's 2 weeks after the second dose, so a little bit later. And so does that mean that you can kind of do whatever you want? Still no, because we still don't understand how people transmit the virus, and we're trying to protect people who can't get vaccinated. So, that is a tough question to answer. And so you have to think about, where are you going? Who else has been vaccinated? These are a lot of nuanced questions that for now, the safest thing to do is to still be careful.
Good.
Yeah. And we've reached our last of the 50 sudden death questions that we've asked you. So the last one is, will the Pfizer and Moderna vaccines work against the variants, or do we know?
Right. So we don't have a lot of data yet that's been peer reviewed, but the early studies looking at both Pfizer and Moderna are promising that some of the variants are still effective. There has been some of the variants, like in South Africa, for example, where there's a little bit of reduced antibody production, but we're still learning more about this. And so to prevent this type of issue from getting out of control, the faster we vaccinate, the better off we're going to be. But still, even if it's not as effective, we do know that these vaccines are effective at preventing severe disease. So looking at the trials, in the Pfizer trial, there were 10 people who had severe disease. Only one of them were in somebody who actually got the vaccine. And in the Moderna trial, 30 people had severe COVID, none of them in the vaccine trial. So it's really promising. So even if you did get an infection to these variants, it's likely that it would be less severe, which is also very helpful for us.
And as a bunch of people have said, you're smarter than me. I didn't come up with this. The biggest thing that determines if we get more variants is just more and more replication, more cases. So everything we do to bring case numbers down to have fewer infections decrease the chance of a new variant that the vaccine doesn't protect against.
Right, absolutely. So all the mitigations in terms of social distancing, mask wearing still apply whether you're vaccinated or not. And the more we hunker down with that, the less likely those things will happen.
Right. Well, Zach Rubin, thank you so much for being here with us and answering everybody. I think we've covered everybody's questions. I don't know if there's anything else you guys have thought of since we planned this episode, but I really tried to pull all the questions I could off of Twitter from healthcare providers and just the lay public as well, and get all their questions kind of put to rest here.
Yeah, it was my pleasure. Thank you so much for having me.
Great. Thank you.